Hello, hello, hello. Once again, thank you so much for joining me at Kopi With Vans. This is your host, Vans, here as usual every Wednesday at 9 p.m. And I'm back. And today's topic is all about thyroid awareness, and that's a focus that we have in the month of January. And I have two great speakers, very knowledgeable, very humble, and they're actually quite handsome as well. Probably all the ladies out there. Okay. Yes, so today we're going to talk a lot of stuff about the thyroid, and something that we don't talk about it very often, unless there's some kind of signs or presentation that comes in. Then we start to wonder what's happening, and then we go to the doctor. I think so. We have a different speakers here, and one is a general surgeon. He's a consultant as well, who does full thyroidectomy, and then we have Dr. Ben Ng, who's an endocrinologist, who's going to talk a lot about stuff. But it's just going to do a quick introduction on the thyroid itself. It's actually a kind of a butterfly shaped, and that's what I know of. And it just sits at the back of the neck. It is responsible for many functions, especially crucial to human health. And the rest of the informations, like the hormones, the tyrosines, the medications, and hyperthyroidism or hypothyroidism, all these stuffs, I will leave it to the experts. I'm going to invite Dr. Ben Ng, endocrinologist. Hello, sir.
Good evening, Vance.
Good evening. Sir. How are you today?
I'm okay. I'm okay. Only the part about you saying handsome, I think the screen has a problem.
No, no, no. I mean, that's a honest thing I'm giving. But probably the next speaker who's going to come out, I think he's way much more handsome than the both of us. Don't you agree that?
No objection.
Yeah, we are. We are. We have Dr. Jaideep Rao. Hello, sir. How are you there?
Hi, good evening. There's one thing that I don't try to dispute is a bad or a wrong rumor. So if there's a wrong rumor that's going, but it's in my favor, well, so be it.
So definitely you're a
Good to
popular
see
doc
you.
among
Good
the
to see you,
CLS.
Vance. Good to see you, Dr.
Thank you.
Ben.
Thank you, sir. Thank you. Thank you so much to the both doctors. Like I said, always in my talk shows, whenever a doctor who comes in, they put a lot of effort, their time. Probably you should be resting. I can see from the faces of yours, you both had a very long day as well. That's for sure, right? But I'm just going to jump into the topic itself because the month of January, it's all about thyroid. I'm going to pose the first question to Dr. Ben itself. Dr. Ben, I mean, we know, I mean, that is your expertise. Before we even want to get started up, do you want to just talk a little bit on the thyroid itself, sir?
Yeah, well, I think in simple, I think you've given an excellent introduction to the thyroid. The first thing is that the thyroid is a butterfly-shaped gland. It's just in the front of your neck here. And sometimes you actually put both your hands on your neck and you swallow. Sometimes you can actually feel it, and it's not an uncommon thing. The thyroid has only one main function, is to produce thyroxine, which is the hormone, thyroid hormone. And this is where if you Google thyroid hormones, you get about 1 million hits because there's a lot of interest in it. Thyroxine is basically something that controls metabolism. So ultimately, it's an energy hormone, and it affects practically every part of your body. It's important for metabolism, which is energy utilization. It helps the heartbeat. It helps bone health. It helps the gut. So it has multiple functions. And I think when you come down to Thyroid Awareness Month, it's important to appreciate the fact that thyroid conditions are common. They say that up to 16% of women have a thyroid problem sometime in their lifetime. So it's a very, very common thing. The other thing to say is that it's almost predominantly a women-related problem. There are 11 women to 1 man. So it's it's common, but it's predominantly affects women. Now, the other thing which I think causes a lot of confusion, because a lot of my patients come in, and this is where the differentiation between myself and Dr. Rao happens, is that when people come in and they say, "Hey, doctor, I got a thyroid problem," what they don't understand is essentially, very broadly speaking, you divide thyroid problems into two types. One is the thyroid function, in other words, the inability for the thyroid to work properly, and a problem with the thyroid structure. In other words, the shape or something's inside the thyroid. And this is where the differentiation between myself and Dr. Jaideep Rao is. I deal with the problems within the function of the thyroid. In other words, people in the audience, we may have heard, "Oh, my thyroid is too high, is too low, is inflamed. And issues like that is where the remit of an endocrinologist comes in. We treat and we try to normalize thyroid function. However, when there's a problem with the structure, there's a nodule, there's scarring and so forth, then occasionally surgical therapy is required. That's where Dr. Jaideep Rao is coming. So in simple things, again, the difference between function and structure, for example, you can always hurt your hand. You can have an injured hand. The hand looks normal, but it doesn't work very well. So it doesn't always have, it can be linked sometimes, but there are differences between the two problems, and you need different specialities to look through them.
Dr. Ben, coming from the expertise of your field, from the endocrinologist, we often hear this, right? It regulates the body metabolic rate, the controlling of the heart rate. That's a bit scary. Muscle, digestion, function, brain development, and even bone maintenance. So with such a big spectrum, we're definitely going to go back to Dr. Rao in a while on the thyroidectomy. But in your words, how do you manage this? This seems like a big puzzle that you have to put everything in one piece to make sure that there's so many tests have to be done. How do you arrange this, or how do you go about that, doc?
I don't know how to answer that question in a rapid in a short space of time. But I think the challenge is as follows. I think when you look at the thyroid functional issue, you start from the beginning, and you say, is there a disease process? You go through, you talk to the patient, you find out. Because when you talk about function, you have to understand that when I say, high thyroid, low thyroid, it's a lot more complicated than that. Because if you talk about function of a hormone, for example, it's not very different from vision. It's not I can see or I'm blind. That would be very straightforward, but it doesn't work like that. It's I can see, but I can see not very well. I'm long-sighted, I'm short-sighted, I'm very short-sighted. And it's the same with thyroid function. If your thyroid is borderline high, it's very high. There are many degrees of that. And obviously, the worse it is, the very high and very low, the more symptoms you get, and the more it can affect your health. The challenge in treating thyroid is to really find out at what level do you need to treat. Another example, which is similar to it, is like blood pressure. I'm sure many people in the audience say that, doctor told me I got blood pressure. But not everyone receives medication. Because ultimately, the time to treat the treatment must benefit the patient. And this is where the challenge comes in. You don't, every low thyroid, let's give medicine. Every high thyroid, we give medication. So to answer your question in an indirect form, you're right, it affects a lot of things. The worse the thyroid is, very high or very low, then the more likely the other organs are going to be significantly affected. Then we treat. So I think the challenge of any physician when they see a thyroid is to look at a number, look at a patient, and decide, listen, maybe I can hold off for a while, maybe we can try lifestyle treatment, or we have to treat. And how long and how much to treat is the next challenge.
Thank you, doctor. We will definitely come back again with more. But I know this topic we can talk for days and days, because it is not just taking care of one element; it's going into different specters. But I'm going to cut short that. I'm going to go to Dr. Jaideep Raj Rao. So you are the guy who's. Probably I would love to go out at dinner with you, and I want to see how do you actually cut the chicken or whatever the meat there. I think that will be a very precise. I do believe that there's a lot of practices that you put in. But what is thyroidectomy? And I'm sure a lot of women out there, or even men out there, whoever that went through this, they know about it. But in your words, what do you call a thyroidectomy is all about?
Yeah. Thanks, Vance. I would also like to have dinner with you sometime. This almost looks like we're asking each other out on a date. But that aside, I'm not sure whether you really want to see me cut, vegetables and things like that. I always get reminded, of course, of my mom, who always makes fun when I cut my vegetables. She say, "Be careful! It's a very sharp knife," and I have to look at her with an eyes roll to say, well, every day I use very sharp knives. So, but yes, coming to thyroidectomy, essentially thyroidectomy is removal of the thyroid gland. But again, this is can be either what we call as partial, where we remove a part of it, or we do remove most of it, what we call a subtotal, or we remove the entire gland, which is called total thyroidectomy. As you know that this is a butterfly shape, so we have the right side, we have a left side, and there's a connecting bridge which is called as the isthmus. So I think, as what Dr. Bannon put it uh, very simply and very clearly, essentially the thyroid gland can be divided into two issues, which is the functional issue and once the structural issue. And most of the thyroid issues are actually handled by an endocrinologist like Dr. Ben. And because the most common presentations of patients is whether they have a hyper functioning thyroid or a hypo or a low functioning thyroid. Now, most of the times, this can be sorted out with medications, and which I think Dr. Ben will talk about later. But when there is an issue, for example, there are thyroid nodules, and when it comes to these thyroid nodules, that's where the surgeon comes into the picture to decide whether this nodule needs to be taken out or not. So, in sometimes this thyroid functioning, for example, a hyper functioning thyroid gland can be a result of a nodule that is overacting, and it produces excessive, hormone, the thyroxine hormone, and this results in certain problems like patient's heartbeat goes up, their blood pressure goes up, they lose weight, they lose appetite, and things like that. And if this nodule is hyper functioning, then even with a high amount of medication, we are not able to keep that thyroid level under control. And that's where someone like Dr. Ben will refer this patient to me to see whether that nodule can be removed. Of course, the main concern for us always is the fact whether these nodules are cancerous, and that's one of the main indications for which we actually remove a thyroid gland. So, in a sense, thyroidectomy is removal of either a part or a total of the thyroid gland.
Thank you, Dr. Jaideep Rao. Thank you, sir, for that. We'll come back to Dr. Ben. Dr. Ben, what are the symptoms that increase or decrease in the thyroid activities?
I mean,
We can even. Yeah.
Yeah, we talked about it briefly. Essentially, again, going back to the basics, thyroid is an energy hormone. It's a metabolic hormone. So the symptoms you have, again, depends on the degree. If you go to Google now, you find a high thyroid, you get a classical fast heart rate, weight loss, tremors, and palpitations. When you have a low thyroid and your metabolic rate is low, you're tired and weak and you gain weight and so forth. The important thing to appreciate, number one, is not always classical. So I've seen patients with very high thyroid and don't feel anything, and similarly I've seen patients with low thyroid and don't feel anything, and there's everything else in between as well. Many patients have what we call subclinical disease. In other words, you can see some abnormalities within the blood test, but they don't really have any symptoms. So I think it's very important when you talk about the symptoms of increased and decreased thyroid. There are some classical symptoms, but the problem is usually these are quite extreme. The most subtle ones happen when you're just a bit off, you're a bit tired, intermittent, some palpitations and all that. And the problem in many cases when it comes down to thyroid is that the problem happens very slowly. So many patients can have thyroid for months and months and months, and then because their symptoms develop so slowly, think I am just getting older, I'm just stressed at work, and that's the thing that's causing the problem. So it's important to, I suppose, listen to your body because the symptoms can be quite subtle. You muted yourself.
Thank you. Doc, Dr. J.D. Brow, we talked about this thyroidectomy, the full thyroidectomy, removal of the whole thyroid gland. But, in some cases, there's only the surgeon decides that, of course, with the patient as well, they only remove partial for some reasons. They also want to leave it there. But some feels that it could be cancerous or maybe it can reoccur back and they remove fully as a thyroidectomy. So is there any options for people? I mean, say they know I want to keep partial of that. At least I want to keep partial of that working rather than taking fully out and then relying on medication for the rest of my life. So there used to be a little bit of a confusions in the past. What is your take on that, doctor?
Yeah, so usually the type of surgery that we'll do is dependent on the pathology of the thyroid gland. So, for example, sometimes a thyroid gland is enlarged, and when we do the commonest investigation that we would actually do to look at the anatomical uh, part of the thyroid and any abnormality would be an ultrasound of the thyroid. And if you need to do more, then we would either do a CT scan or an MRI, or sometimes if you're looking for cancer, then it would be a PET scan. Now, in this, the simplest pathology would be a thyroid cyst, a cyst that is actually increasing in size, which contains inside what is called as a colloid, which is one of the some of the cells that don't function and goes to sleep. And if this cyst is there, sometimes a simple situation is actually just aspiration of that cyst. So we just, under an ultrasound guidance, we just use a needle and we'll be able to aspirate that cyst. Of course, this is done mostly for cosmetic purposes, because usually these cysts are harmless, but because it is, it's something on the neck and it looks like a big nodule on the neck, and a simple aspiration is good enough. Of course, always in the back of our mind, we want to rule out any cancer. Again, sometimes we get, sometimes a nodule in the thyroid gland. Now, if the nodule is located either in one of the lobes, so we have the right lobe, we have the left lobe, or we have the isthmus in between, then there is an option to actually just remove that part of the gland. In a worst case scenario, if we do take it out and we find that, so what we do before that is, if there is a nodule, again we would do what is called as a FNAC, or fine needle aspiration. And in the fine needle aspiration, we want to see whether this is cancerous or not. So if it is not cancerous, then of course we would just take out that nodule, and that would be good enough, and we don't need to remove the entire thyroid gland. Again, if this particular one nodule is hyperfunctioning, then just by removing that nodule itself, we would have cured the patient, and they don't need to remove the entire thyroid gland. But when we do that FNAC, if we do find out that it's cancerous, or sometimes when we do the FNAC, we may not be able to get the exact diagnosis. In such a situation, we would need to remove that nodule, and we intraoperatively, we would send it for something called as a frozen section, and we would see whether this is cancerous or not. If it is cancerous, usually we would need to remove the entire thyroid gland, unless it's a really small, less than a centimeter, cancer. Then it's okay. There's an option to actually preserve some thyroid gland, but usually otherwise, then we would remove the entire thyroid gland. But again, cancers of the thyroid gland are not so common. Most of the time, especially in Singapore, we remove it for nodules. So it's either a single nodule or it's multiple nodules. Again, if multiple nodules is located in one end of the lobe, we can actually just take that out. So it's on a case by case basis. It depends on the pathology of where it's located, and depending on whether there is a functioning or non-functioning, then we would actually discuss this together with the endocrinologist and plan out the surgery for the patient.
Thank you, doctor. Dr. Ben, I mean, of course, we do see these. I do see these cases quite often. People get very fatigued, very tired, long hours of sleeping. Even they wake up in the morning, they feel very lethargic. Sometimes they say, "Oh, you know what? I'm not enough food, or I'm just not enough rest. Probably my minerals and vitamins are not there." So it is a certain kind of a presentation to categorize into these two category of hyper or hypo. Unless I come and check. So when will I know what are the parameters I have?
The excellent question. We touched on it the last time. The main issue in many situations, they are classical symptoms, and they are not so classical symptoms, because again, the condition can develop quite subtly. But classical symptoms of hypothyroidism, remember, I think in simple terms, always remember, is metabolically related. Hypo means your thyroid levels are underactive. So when your metabolic rate is very low, you feel very tired. You tend to gain a bit of weight. In women especially, they tend to lose their periods. They have changed in their bowel habits. Their hair, there's increased hair loss. So that's one of the mechanisms. Hyperthyroid is again the opposite, where you have an overactive thyroid or very high metabolic rate. So when that happens, if you're very anxious and so forth, there's that same kind of feeling. You feel very sweaty, your heart goes very fast, you feel a bit of tremor in your hands, your bowels again get affected, you can get a bit of joint pains. So these are all potential causes that you have. And always, I think the message is it can be quite subtle. So I think it's important, again, listen to your body. If you think there's something wrong, remember, it's not always thyroid, although it can be a relatively common condition. Do see a doctor if you have any of these symptoms, and get it investigated.
And then also, doctor, I mean, for Dr. Rao, probably both of y'all have seen these cases many of a time. But Dr. Rao, it's pretty difficult to breathe with a nodule. I mean, because of the congestion in your throat area and your windpipe and kind of stuff. Is there also be a reason where people delay this operation? And so what? I probably wait for another 1 year or 2 year, or maybe they go into different remedies of different medications out of the medical science. Is there, I mean, of course I won't be asking it's good or bad, but in the aspect, is it okay to delay the process of this full thyroidectomy or even partial thyroidectomy or partial removal of it?
Well, usually we would not recommend to delay the process of actually diagnosing the condition. And once we diagnose the condition, if we require any intervention, then of course we don't want it to be delayed. So of course the alarming symptoms of the thyroid gland is, of course, a swelling that is there. Swelling that is there. But you're right that a lot of
Dr.
people,
Rao,
they
I think the
just
Wi-Fi connection is a bit of
dismiss it as
delaying
well.
because we're
Okay, the
getting
neck is thickened, and sometimes people are on they weigh a bit more heavy, and they have a lot of neck fat, and then they don't pay attention to it, and then they feel they just gain weight, and they delay their
is doing I think you got a Wi-Fi connection issue because we are getting like 10 seconds delays, dog. Dr. Rao, it's a
so-called
very
treatment or diagnosis until they have some
no.
difficulty in swallowing, some difficulty in breathing.
Okay, we lost him.
Yeah.
Dr. Rao,
Or there is
Dr. Rao.
I think we lost him.
Yeah.
Coming back.
Okay. Uh,
Well, tell you, while we wait for Dr. Rao, oh, sorry.
guys, yeah.
some hoarseness of voice. So, if you have a, can
Dr.
you hear
Rao?
me?
Yeah, but we are hearing 10 seconds delayed. So I'm sorry because whatever you have said earlier was partially absorbing, but then partially we are not understanding.
Hello?
So yeah. Yeah. Is it better right now? Can you respond right now? Okay, now, Dr. Rao, we will come back to you in a while. I'm going to go back to Dr. Ben, and then we will just push it on there. All right. Dr. Ben, I know there are a few tests. These numbers probably you are like, you see it's like having a coffee every day. But the TSH is a bit interesting, I find it. The thyroid stimulating hormone, the stimulation. You know, how often these tests should be done on a humans or we, like for myself, how often should I do these tests?
Well, I think for yourself, remember, first of all, risk factors I think that thyroid is a relatively common condition. Therefore, I think in the absence of symptoms, it should be done along with your health screening. So I think every year or so is not unreasonable to do that. If
Sorry.
you're planning,
Did you
He's Doc. We are losing. We have lost you. Can you hear us? You want to try logging in again? Try logging in again. Okay.
okay,
All right, Doc.
yeah.
Sorry.
So,
Talk about it.
yeah, I think we should do it along with your health screening. However, remember, if you start having symptoms and all that, or particularly in ladies, if you have a family history of thyroid, you had thyroid problems before, or if you're trying to get pregnant, checking your thyroid levels often, every 6 months or so, is very, very helpful. At least you know where you stand. I think that from with regards to thyroid disease, remember that the results can be subtle, but especially it's a predominantly women-related problem. It's very important, as you correctly pointed out just now, for brain development of a child. So we have to make sure at circumstances like that that the thyroid has to be very well controlled, not just borderline and so forth. It has to be very well controlled. So for women who are planning to get pregnant, definitely check it once. If you have a previous history of thyroid disease, check it regularly. And for others, just check it annually, all along with your health screening, or if you develop symptoms.
So these tests should be done on a yearly basis. But how about doctor? Those just thinking that I'm tired, I'm not rest. I mean, I'm repeating the same thing. But why am I asking that? Is I think a lot of people are trying to go and do their own recoveries, and like you said, the information out there in the Google is so much. Why am I feeling tired? So there's another list of words that's come in. Not enough water, not enough sleep. So they're trying to do these diagnoses on their own self, and I feel that sometimes it could be dangerous because you're delaying the process, especially like for thyroid nodules or goiter, because your neck start to swells up, and then they say, oh, probably it's eaten, and they give some kind of excuses. So that could be also be dangerous doing self-diagnosis. What is your take in that, doc?
I mean, the problem with thyroid disease is that, as we mentioned, it affects all parts of the body. And the issue is that everyone, and the most common is they come and say, Doctor, I'm gaining weight, must be my thyroid. I think a balance has to be struck here. It's very important that, if you think you have a problem, please see a doctor. But at the same time, it's also not to be too extreme and blame everything on the thyroid. I mean, this is how I would advise anyone to approach a thyroid condition. First of all, if you have a funny thyroid result, or you think you have a thyroid disease, or you've got family history and all that, start from the basics. Question one: do you have a thyroid disease? You can remember there are fluctuations of the thyroid level. It can fluctuate up and down depending on what you do when you're excited and all that. When you're sick, it can go up and down. Is there a disease process? Is there some inflammation? Is there some nodules? Is there something that's causing the thyroid to be abnormal? And if the answer is no, then there's no treatment required there. If the answer is there's some kind of thyroid disease, then measure the time in which you need to actually intervene, yes or no. If you have a nodule there, how big is it? Is it growing? Is it serious? If it's high or is it low, how high is it? Does it need to be treated? Can we hold on for a while? What are the circumstances? You want to get pregnant, then you may need to treat it. If it's borderline, maybe we wait and see. Maybe we try and treat for a couple of months. So each condition and each presentation is different. So I think it's very, very important not to just rely on the blood tests per se. The important thing for anyone listening out there, if you have an abnormal thyroid level, remember that when you are checking that thyroid level, I'm not even saying whether you have a disease or not, you are measuring your thyroid function at that time. In other words, if you're running on a treadmill, you got a high fever, and you check your thyroid levels are going to be high. Why? Because your metabolic rate is high, and that's a normal phenomenon. So don't base everything on one result and say, oh my goodness, my TSH is very low, is very high, I got disease. Go back to the basics. I got an abnormal thyroid. What caused it? Is it physiological? Was I unwell that day? Which is possible. Could it just be fluctuating at a borderline level? Or do I actually have a disease? If you have a disease, then that needs to be looked at.
Thank you, doctor. Dr. JB Rao, Mr. Jaideep Rao, doctor, we lost you for a while. Are you able to hear us now, doc? Doc? He's story. Okay. I think now it's more than 10 seconds right now. Okay. Okay, Dr. Ben, I think we have to because he
Maybe
just
we
seemed
tell
that
him to use his 4G.
yeah, yeah,
Maybe
I
that
think
would be
yeah,
better,
yeah,
isn't it?
I've
Yes,
already informed him.
yes, yes. I've been
Um,
able to. Yep.
can you hear
Can you
us,
hear
doc?
me?
I think
Yep.
yes, we can, but now it's like 20
You can
seconds
hear me, yeah?
delayed. I can hear you,
Oh,
but we got to wait for about 20 seconds before you get the answers, and then we have to wait. So it's more than 20 seconds. Maybe it's your connection, doc. Maybe you want to check that out first. Okay, so yeah. Okay, we were so like
I'll take the
the
next
more
question
questions are
while he
coming
gets
up.
himself sorted
Yeah,
out.
while he's trying to
yeah,
recover on
yeah,
that. Then the
very well.
doc. Okay, just okay. Oh yes. So your connection.
Okay.
There you go. Okay, so now at least Dr. Ben can have a little break. Oh, okay. All right. Okay, so Doc, the previous question that I was posting to you. We see that. Okay, JR Surgery Arden. Okay, that's Dr. JD Rao from there, Mount Elizabeth Novena. So it seems like you have to behind your logo, then the connection is stronger. Well done. And to be very honest, you are way much more brighter now. So you know,
Okay.
the we were at the topic of nodules. You were mentioning about rather than doing a full thyroidectomy based on situations and based on patients and what is the cause of it, is it cancerous, biopsies and all to be done. But it's for some, I know a few cases that my friends that they did a full thyroidectomy. All right. So it's lifelong have to go on medication, so that could be another worry, another anxiety. There's also a study shown that people who are going to go for surgery sometimes they go into extreme sense of anxiety and depression. I'm sure you have faced that as well with your patients. So whole, what will your recommendation be, doc? I mean, how do you take it step by step?
So I think the one thing to remember is that most of the thyroid disease, or for example, let's talk about thyroid cancer. Uh, the most common thyroid cancer is what we call as a papillary cancer of the thyroid, and that is probably one of the cancers with the best prognosis. So if you ask me that if you had a choice to choose one cancer, if God or the devil said you need one cancer, you just choose one cancer that you want, then the best cancer would be a papillary cancer or a follicular thyroid cancer, because this is slow growing, and just with the removal of the thyroid gland, you could get very good prognosis and more than 95% completely cure rates. So yes, in when the cancer is slightly larger and you have to remove the entire thyroid gland, it's still not too bad, because you can still take just one tablet a day supplementation, and then still is okay. So it's one of the surgeries with the least morbidities, and the great best prognosis. So we have a lot of patients who have had these cancers and we have operated on, and you know they've lived after that, completely cured. So that's the good side of it. Of course, nobody wants to have cancer, and no, that's the worst word. The C word is like the most taboo word. But if at all in the body, this is probably one of the better. Of course, there is another type of cancer of the thyroid called anaplastic, which is quite bad and very aggressive. But thankfully, it's very very rare, and we don't see that very often. And more than 95% of the thyroid cancers are papillary cancers, which have got good prognosis.
Maybe I pose these questions to the both experts here. Doctors, I mean, why exactly a goiter comes in, or why exactly nodules comes in? Is there any particular reason? Is it because of stressful lifestyle, or it's because of the food, or because of hereditary that pass it down? Is there any particular reasons why someone will have these two symptoms? Dr.
I'll
Ram?
take it first. Yeah,
Okay, sure. Dr. Ben?
sorry, Ravi. Okay. Essentially, from my perspective, the most common reason that why you develop thyroid nodules is from an inflammatory process. Remember when we first divided the thyroid problems out to a functional problem and a structural problem, the mechanism on why most people develop thyroid functional problems is due to an inflammatory process. We call that an autoimmune process. So ultimately, what happens is the body produces antibodies that attack the thyroid gland. And when that happens, when you attack anything, it gets swollen. And when it swells up, you call that a goiter. So essentially, if you go and look at some ladies who have thyroid disease, in their neck is just a bit swollen, and that's simply what you call a goiter. Now, in many cases, because of the inflammatory process, if you cut yourself or you hurt yourself and so forth, you'll realize that there's a bit of fibrous tissue and so forth. And this is literally what we call thyroid nodules. These are areas of inflammation which have cleared up and have healed. And this is where you get this scarring process. And many of these appear as nodules on ultrasound. The other times, and I don't know whether Dr. Jaideep has anything else to add to it, is that sometimes they just happen as you get older, you form nodules, it runs in the family. And it's just one of those things that happen. It's a common enough finding. 12 to 15% of ladies have have nodules in the thyroid, and it's not usually something you worry about. It's common to have things like in ladies, when you do breast ultrasounds, mammograms, and to breast nodules in the lung, they are a normal finding.
Thank you, doctor. Doctor, when you talk about these surgeries, especially for full thyroidectomy, it's a major. Do you call it a major surgery?
Yeah, well, kind of, yes, I would say.
And the recovery period, doc, pre or post? In fact, more about post, because pre is about you're preparing them psychologically, physically, mentally. I think that's very important. But what is the recovery period that we are talking about after these surgeries?
Actually, this surgery has evolved over the years, and now actually this surgery is very, very safe, and the surgery can be done, you know, very, very safely. The recovery period is very fast because it involves a tiny incision, along the neck. Nowadays, also we can do this in an endoscopic manner with keyhole surgery or even robotic surgery. But even if you do it in the traditional manner, which is like making it a transverse cut, the surgery is relatively so-called with a very low rate of complications. And usually the patient is all worked up beforehand. Usually they get admitted on the day of the surgery, undergo the surgery, and usually the next day or the day after that, they can actually go home. So if you take out just a part of the thyroid gland, the next day they can really go home with no issues at all. If you remove the full gland, also actually they can go back only if they have been having some thyroid fluctuations. Usually we'll keep them for a day or two to make sure that they stabilize. So usually it's done with a multidisciplinary. So usually an endocrinologist like Dr. Ben would monitor this and see how the hormones act after the surgery. But most of the time, they just need to stay for a day or two after surgery, and they can go back home.
And doctor, one more for you, also the same, a little different on that. When you talk about these recovery periods, and also, does women see most of the time they have these issues, or men? Because Dr. Ben mentioned it was woman, right? Dr. Ben, correct?
Mm-hmm. Yes, that's right.
Yeah, it's more for the woman. Does men also have a certain percentage on this?
Yeah. So thyroid disease is more commonly seen in women, but we do see even occasionally we do see men having these problems, and classically they have nodular. Usually when we see a nodule in men, we are a bit more concerned, and we want to make sure that it's not cancerous. Whereas in women it's a very common disorder, but most of the time they are not cancerous. They are mostly just hormonal fluctuations, physiological, and so they have multinodular goiter or single goiter, and usually this less serious when as compared to men.
Thank you, Doctor. Dr. Ben, I got one more last question for you, and also for Dr. Jaideep. And I think we are almost at 45 minutes. And some of the viewers actually typing the comments in another Facebook account in my personal one, which is good. But I will not be able to bring it out to the doctors because you are posting there. So I kindly suggest that you post it in the Kopi Events Facebook so that I can bring it to the doctors as well. Because some of the viewers has already said thank you, good presentations, and so on and so forth. Dr. Ben, if someone have done a full thyroidectomy and the person has a diabetes, is it consider a very crucial part where that particular person have to take charge of their life?
Well, let's start by saying that I think for both thyroid and diabetes separately, you need to take charge of your life. But I think to answer it another way, the problem is that thyroid and diabetes are very closely linked. Remember, we talked about this before. Diabetes is a metabolic problem. Is your body's inability to use energy properly. In this case, sugar. And thyroid hormones is a metabolic hormone too. So ultimately, people with severe thyroid disease can have problems with cholesterol, with sugar, with blood pressure, regardless of diabetes. So if you're looking at someone who has had a thyroidectomy by Dr. Jaideep, for instance, then the metabolic rate is already affected. And no matter what you say, and I think this is quite clear, no matter how good your endocrinologist is, if you have a thyroidectomy, you are underactive. We will try our best to replace your thyroid to the best we can, but nothing does it quite as well as God, the one God gave you. So replacement will not be perfect. So there will be increased risk. It may be a bit harder to control your cholesterol and sugar as compared to before, but these are just things. And I think, therefore, it's very important that if you're considering a thyroidectomy, speak to a good surgeon like Dr. Jaideep Rao. Find out why you need it. Sometimes you do need it, and the benefits outweigh the risks. But don't remove it if you think that maybe you can conserve half of it, or maybe you can just observe. There are many, many different indications, and you have to be sure what you're doing.
Thank you, Doctor. One last question for Dr. Jaideep. Doctor, I mean, if someone who walks into your clinic and probably they already know they have a symptom, or is that a particular way that you diagnose a person with a situation? What is the kind of evaluation that you do?
Yeah. So most of the patients who come, usually actually they are referred by the endocrinologist, because usually patients have some symptoms. They either have a swelling in the neck, and then usually they have either functional problem where the thyroid hormone is up or down. But usually when they're referred to us, usually almost always they'll have a nodule or something in the neck. So how we usually, the algorithm we go is that we find out what this swelling is. Now, if it is a diffuse enlargement of the thyroid, like Dr. Ben suggests, this is mainly due to an inflammation, and usually because of the swelling. And usually when the swelling and the inflammation subsides, usually it will go off. So usually very seldom there's any indication for surgery for a diffuse swelling. Next would be that if there is multiple nodules in the thyroid. Again, if there are multiple nodules in the thyroid, usually with an ultrasound, we'll be able to see whether any of these nodules are suspicious or they are just benign. And if we have any suspicion for any nodule, we would usually use a needle to fine needle to actually aspirate to test to see whether any suspicious features are there. Or we would actually do a surveillance and see them again with a repeated ultrasound to see whether these nodules are increasing in size. Many times, sometimes you'll see a nodule, but after like 3 months or 4 months or 6 months, when we repeat an ultrasound scan, these nodules have actually decreased in size. And that's because as the hormone function goes up and down, and this is related to the cyclical functions in women, and also actually even in men, that these nodules can be hyperactive, active, or even dormant. And so we find that these nodules are smaller in size, and then we don't need to do anything about it. But if there is a persistent nodule, if this nodule is increasing in size, if there is any suspicious features in these nodules, like it's a bit hard, there's some calcification in it, it is irregular, and if the fine needle aspiration shows some atypical cells, then we would discuss the possibility of doing surgery. Now, again, as I said before, if there is a single nodule in a particular lobe, then we can actually just remove that part and then see what the pathology is. And then depending on that, we can do. Usually, we'll always try to conserve as much of the thyroid gland as possible because, this will make the patient less dependent upon hormones, and the normal functioning can still continue in the future. Of course, if there is, some cancer and stuff like that, then there's no choice. Then we would have to remove the entire gland.
Thank you, Dr. Jaideep Rao, sir. Thank you very much. And also to Dr. Ben. I think we covered a lot. I know these topics is not just a simple topic because we can go even more deeper on that, the kind of details, because it controls the whole body. Dr. Ben, you have said it very clearly because of the thyroid, your bone mass, your muscles, your heart. It looks like it's the main nerve center compared to the brain as well, because these guys actually rather controlling everyone in the body. It's like a conductor in a symphony. Can I say that? Or your brain?
You can. The problem is you can say that for a lot of other things in the body as well. But you're right. I mean, the thyroid is a common problem. I think it's very important to appreciate. First of all, it's common, but not that common. I think from my perspective, there are two bits. One of it, please don't look and they blame everything on the thyroid level, thyroid gland. At the same time, don't ignore abnormalities within the thyroid itself. It can be serious. The health issues can be catastrophic if you leave it. But at the same time, mild disease is common, and don't blame everything on it. If you're tired and your thyroid is borderline, it may not be the thyroid, it could be something else. So do look around and speak to your doctor if there's any concerns.
Thank you, Dr. Ben, for that. And Dr. JD Rao, I mean, like I said, we have to go for dinner.
Yes, you should
Um,
have that. This could be a thyroid issue.
yeah. And I just say, Doc, I think we have to go for a dinner because I need to see how you precisely doing it, how precise and how carefully you're doing it. I think it requires a huge amount of practices, and I think all the human life depends on the doctors. I mean, at certain point of time, right? Because you really, it's like angels, like I always says in my talk shows. Thank you so much, doctor. I mean, I know the both of you are exhausted from a long day at clinics and hospitals with your routines and kind of stuff. But with that, despite that, you also spend good 50 minutes with us on the Thyroid Awareness Month. And it's been a pleasure to have the both of you. Thank you so much, Dr. Benz. Thank you so much, Dr. Jaideep. And probably we will meet up for coffee or Kopi with Vans. Probably why not beer with Vans? I think that sounds better.
Yeah, Vance.
Yeah.
At 8 o'clock at night is very late. It's not the time for coffee.
I think so. Need to change. Sometimes need to change a bit. Can't be
Yeah.
just relying on coffee. But then again, thank you so much. We'll stay connected. Thank you so much, doctors. Thank you so much, Dr. Ben.
Thank you. Take
Thank
care.
you.
Good
Okay, good night.
Bye. And thank you. All right. So that was the two lovely doctors who came on board with Kopi with Vans, and we talk about thyroid. The month of January is, wow, it's almost done. Huh? January is always gone already by the wind. 2022, that's right. So February, it's coming up. Another set of awareness month that we are covering. Interesting speakers who are coming in as well to talk about it. But my greatest gratitude to Dr. Ben and Dr. Jaideep. I know how doctors, we all know how doctors are extremely busy. And if you look at them, Dr. Jaideep is still in his clinic. And I think Dr. Ben also looks like it is in the clinic. Both of them are actually having a long hours, but despite that, they have spent a good 50 minutes. I mean, having a chat with doctors, I think, is one of the greatest because you understand so much of things, go through a lot of other individual things like the thyroids. And what I also know, I found out that, usually before a talk show, I go into things like, imbalance, distributing the thyroid glands, or even hormone production to varying degrees. And it just keep on going, all right. And also when you talk about thyroid, mood swings, if someone doesn't have that, that's breathing, that's heart rate, like I told before earlier, that this is something like a symphony. It's like a musical symphony is going on, and the conductor is either constantly conducting in our body, and our greatest heart is, I'm pointing right, yeah, the greatest is happily drumming. Other functions are going on, like the kidney, the lungs, the oxygen production, the deoxygenated oxygenated blood. Wow, it's an amazing piece of I can't say it's a equipment. I don't know what to call that. We some call it a body, some call it it's a temple. We can call whatever we want, but if we are not taking care of ourselves within, it's very important. We are always taking care of external stuff, which is also important, but we pay a lot of attention and time to the external sources rather than the internal, mentally, physically, emotionally. So I think these are the important part that we need to cover, and I feel that 2022 is going to be a great year for all of us, and a great topics are going to come in. And it's been a great journey, right? Over the past 2 years at Kopi Events, speaking with so many professionals, professors and doctors like Jaideep Rao and Dr. Ben. So much of information that you can actually absorb in together. Like I always say, put it into the grinder, the juice maker, and then you just drink it. So much of information. And once we understand about the human performance, or the body, the well-being of the body, then you start to take care of yourself, like having enough hours of sleep. Even what happens if you have only 6 hours, your body goes under stress, your cortisol levels goes up. And then what happens? Then you don't function at your maximum level. You get mood swings, you get tired, you get fatigue. Everything happens, right? And it's always been a deficit. It's not a deposit. We need to have 8 hours of sleep, but if you're not doing that on a constant pace, sometimes 5 hours, sometimes 4 hours, sometimes we stay back late to watch our favorite games or do some things or watch a movie, but then the next day you're not covering back, then what happens? It's a deficit, right? um Due to that also can lead to a lot of other problems as well, right? We need to have a good 8 hours of sleep. Our body also needs rest, our kidneys, our lungs, not our heart. Once the guy take a rest, that's it. Okay. It's time for me to sign off. As I usually, not usually, I always say that it's always been a pleasure and a great happiness with lots of great gratitude to be in the show with everyone. And I'm hopefully it will make some sense. And I'm hopefully thinking that these videos and these live videos with the professionals and doctors and professors, so many of these people, eventually it will bring out some great knowledge and information out. Till then, every Wednesday, 9 p.m., this is Vance, or you can call me Kopi with Vans. I catch you soon.